Sorry, it's quite late. Sorry for the delay. We have been preparing everything for you to test the Pectus Up. Thank you so much for your time here, for your attendance. So today we are going to present you the new Pectus Up together with Dr. Manuel Lopez, who is in Arise. He had an emergency at the hospital, so he will be here just for the demonstration and for the discussion with you. It's going to be myself, Pau Moline, from Ventura Medical Technologies, who is the product specialist, and I'm going to present you the product, technique, and everything else. This presentation will be divided in these different points. Let's move on directly to the material. I think that you could see it in the presentation that was presented yesterday. We have the Pectus plate at the upper part, 7 different lengths. According to the CT scan, we are able to choose the right implant for each patient. The same occurs for the sternal screws. For different lengths, it will depend on the thickness of the sternum. The sternal plate is one design, and the plate fixing screws two. And at the lower part, we have the instrumental kit, which is really small. The principles, I think you might also saw it yesterday. We have the Pectus plate, which is positioned over the skin. With a pen or a marker, we can draw the design of the plate in order to know which is the subpectoral pocket that we will have to perform. And we can take the wing of the implant as the incision template. Then we make the subpectoral pocket, we place the implant, and once we have checked that the implant perfectly fits the subpectoral pocket, we mark with an electroscalpel the middle point where we are going to introduce the anchorage system. At this point, we have the sternal plate together with the positioner, which will help us to introduce the 5 screws. All of them are directly tightened to the sternum with a screwdriver, which is preset with a force that will prevent us to slip any of the screws. Once we have the sternal plate fixed and the sternal plate again under the subpectoral pocket, we introduce the ball joint, which will allow us to elevate both symmetric and asymmetric patients together with rotation or flat sternums. Once we have lifted it, we use these 2 screws on the sides to fix both plates together, and then we remove everything else. As you might see here, since the sternal plate is in contact with the other plate, it prevents the screws to migrate. And at the end, we just suture together both pectoral muscles, so we avoid any kind of seroma or infection, because at the middle part of the sternum there is not that much skin or tissue. And here you might see before and after in this 3D model. For the indications, we have treated patients from 11 years old until 46. All of you know the indication for this kind of patients. Better as much young as we can, but you see that in most of the hospitals you have older patients. Complexity, we can treat both asymmetry, sternal rotation, and different types of sunken chest. Here we have 3 different cases, 3 different configurations. On the left, 29 years old, Haller index of 5, and a deepness of 3 centimeters, which is not bad, and a sternal rotation of 33 degrees. Then a pediatric patient, close configuration, and finally a woman, 28 years old, Haller index of 7, and a sternal depth of 2 centimeters. So we have rotation, flat, men and women. Indications, as it was stated yesterday also, Pectus Up, it can be performed in patients with history of cardiac surgery, recurrence of NAS or rabbits. As you might see in the right image, you have a CT scan of a patient who had a NAS bar introduced. You might see on both sides the artifact caused by the implant. So before removing the NAS bar, a Pectus Up was implanted, so the sternum was lifted, And once the sternum was lifted, the NASBAR was removed. And here at the lower part, we have a Marfan patient treated by Dr. Varela in Madrid, who had a cardiac surgery, and before closing the sternum, they treated the pectus carinatum with the rabbit's technique and the lower part with Pectus Up. Our job as company, we always request you to send us your CT scans from the patient in order to evaluate different aspects. One of them, as you may see, is the implantable material selection. Since we have 7 different sizes of Pectus plates, we will choose it according to the distance between the costal cusps. You might see here that it is 16 centimeters. So in this case, we would choose the plate with 164, which is 16 centimeters large. Another point is the sternum thickness. This is important in order to choose the length of the screws. Again, as you might see, there are 4 different lengths. And in this case, we have selected the one that has 14 millimeters because the screw, it has a head of 2.5. Other aspects that can be assessed are all the indexes, Haller asymmetry correction, as well as sternal rotation, in order to forecast any possible complication during the surgery. One other aspect that is very common in Pectus Excavatum surgeries is costal flare, and we usually recommend to be treated it in order to get a better aesthetic result. And finally, the point also that we would suggest you is which is the deepest point or the best anchorage point to place the implant. Here we have a live surgery video, which was recorded in Sevilla.
Subsequently, the implant is fixed to the sternum and rib cartilages to maintain this position after the intervention. It is indicated for children and adults with different grades of complexity regarding sternal depth, asymmetry, and sternal rotation, which will be assessed by the surgeon to choose the right technique. Advantages of the technique: minimally invasive extrathoracic technique, simplicity of execution, reduced risk of damage, reduced blood loss, hospital stay between 2 and 3 days, no ICU stay.
Here we have a summary of the main benefits of this new technique, stated by the surgeons who have performed the surgery. It provides a safe environment for surgeons. It enhances the cognitive knowledge acquisition. It doesn't require a lot of learning curve, and it can be achieved very quickly. It is easy to perform, and since it is an extrathoracic technique, it does not compromise the patient's safety. Because it is attached directly to the sternum, it causes little pain, and hospital stay is really short, so the cost of the hospital are really short. Here we have some videos of patients treated with Pectus Up. As you might see, one of them is in the hospital yet, and he can move around without any kind of problem because they don't have that much pain. This is a benefit, but also an inconvenience, because if they don't have pain, they move. So we have to take care and be persistent with the patients in order to them to let them stay quiet for quite some time. Surgical time, it's average 45 minutes, no ICU stay. Hospital stay, it's around 2 days. It depends on the hospital. Since the product is attached to the sternum directly, it allows CPR to be performed, as well as to the development of the children's chest. For pain control, oral analgesia is used, and they can go back to work, school, university 1 week after the surgery, and there is no mortality. Here's a summary of the cases we have been treating since 2015, when the implant got the CE mark, as you might see here, in America and Europe.
Looking at the past and speaking about the possibility of the surgery for the Pectus Excavatum, we can remember the Ravitch surgery that has no compatibility with this kind of surgery because it's much more aggressive and dangerous for the child. And the same consideration could be done also for the technique of NAS, the insertion of the bars, because in the second case we have the necessity to enter inside the thorax, also if it's only in thoracoscopy, and in the Pectus Up technique, the surgery is all out of the cavity, so is more simple, more feasible, and has less duration and has absolutely less pain and is less difficult from the surgical point of view. For what is my experience, our experience at Bambino Gesù Hospital is a safe surgery, and the capability of the implant to taking up the sternum is more simple than with other techniques. The only point to take in mind when doing this surgery is to have a clear figure of the situation, looking at rotation of the sternum, the deepness of the defect, and to point out all the possibility. What about the association with the defect also of the last part of the sternum? We are speaking of apophysis ensiform. What are the main advantages that we would highlight to respect the techniques that we have used before? Is absolutely well accepted from the patient that looks at the surgery with another eye, because we don't need to, I repeat, to enter inside the cavity, and for the duration of the presence in hospital that is reduced, and obviously looking at another information that is really important for the child, that is the pain, because the governance of the pain with the Pectus Up technique is much more simple than with the other techniques.
These are some cases of Dr. Hernandez, Dr. Molins, and Dr. Fibla team who are doing another line seminar, and that's why I'm showing their images. Their first case, a small child, woman, 12 years old, and a deepness of 2.5 centimeters. And you might see the results preoperative at the upper images and postoperative at the lower part. Again, this is the patient that was shown previously with a Haller index of 7 and a deepness of 2 centimeters too. And you might see in the upper part preoperative images and the lower part postoperative ones. This is Dr. Fernando Cocer, who could not attend also the Congress, and this are his opinions about the Pectus Up technique after some usage. These are some cases that they perform in Sevilla. First case, male patient. You might see the CT scan with all the indexes and the deepness of the thorax, and at the lower part, this image here, you can see which is the deepness between the plate before the surgery and which is the result. So you might see here that there is a gap between the plate and the sternum, which is the one that we want to correct. Another patient from Dr. Congregado, who is here in the Congress, and Dr. Cocer. Again, you might see here between the plate and the sternum there is a big gap, also in this image, that right after the surgery is completely flat. Our patients, Dr. Muguruza and Dr. Bellido, same scenario, big gap between plate and sternum, and the result after the surgery. And this is a pediatric patient from Madrid also. You might see it's really skinny, so this is the type of patients that suffer from Pectus Excavatum. And now, with Dr. Manuel Lopez, he's going to show you a demonstration of the implant and the technique itself here with an animal model. So, please, Manuel.
Innovative technique. So I say that today for the people who perform in the Pectus surgery, there is not room for the mistake. And when you perform in the Pectus surgery, you need to have different strategy, like when you play the golf, for example. Sometimes you need to different club to place the ball in the hole. So even in Pectus surgery, you need to consider different strategy. And today, Pectus Up, and particularly with the last generation, you need to include when you perform in the Pectus surgery. And there are more and more indication, because from the beginning we use the Pectus Up only in cases in patients with history, the cardiac surgery, or in Rido procedure, or in patients afraid with the NAS procedure. But with this very last generation is really easy. You know that when you perform the NAS procedure, sometimes it's not easy as it seems. The procedure requires learning curve and minimal cases a year. But Pectus Up really is very easy to perform and it's very safe, and the learning curve is very few. So I perform around 1250 cases with Pectus Up, and I am happy with the results. So, but I am very more happy with this last generation that I will show you how it works. But
you will be able to see everything through the projector. I think maybe not all of you can see it, but here there is a weight. It's 12 kilos. Then you will be able to test it. So we will lift a sternum which more or less it's analog from a real Pectus Excavatum.
So this case is, so I will use the sternal bone from the peak. So in this size is the head of the patient. And in this case, it will be on Pectus Excavatum with external rotation on the right side. So one of the last generation, this include this new device. This is the sternal plate. This is the sternal plate that it will be to support the sternal and will be going in contact with the pectus plate. So to place you place the sternal plates under at level to the deepest points, you know, like this. So maybe you can see this is the sternal plate that we placed before, just in order to win the time. So, ¿podemos ver acá mejor? Sí, acá. Ver acá eso. So you see this is the sternal plate. So we place five with the screwdriver, ¿cómo se dice tornillo? The screw, yes.
I want to know how you do the holes for the screws.
So
¿Cómo haces los agujeros?
you use you pre-hole the screw using the drill. So you place this system, and before you place the screw.
¿Hay un tope para ello? Un tope para...
No, before to place the screw, you perform the pre-hole using the drill, just to prepare the hole, okay? And then you place the external plates in the external table. And the second step is place all screw.
How do you know how deeply
So you have two pair in this place. You go strong and place her over the bone, and you are sure that.
But you first do holes in the sternum.
Yes, pre-hole. Yes, with the drill.
How you
So the feeling.
how you limit the depth of drilling?
So it's only very few millimeters, just to perform the pre-hole. So it's really
The sternal cortical
only
only.
the sternal cortical. Yes, you are. Yes, it's very easy to know that you are in the good position.
Yeah.
Okay.
You will be able to test it. It's just tapping the first cortical, so the screw will go in. It will depend on the CT scan
So yes.
measurements. So they are per length.
So the size of the screw is evaluated regarding to the CT scan for each patient.
Gracias. Okay. Who has a question? Who has a question, please, for the streaming people? So we can use the microphone, okay? Who has a question? And we need to use the microphone for people to hear the streaming. Okay? So who has a question?
So putting the screws depending on the thickness of the sternal plate through the CT scan. In the deepest point you are going to put the screws and the plate on.
So the size of the pectus plate and the size of the screw is evaluated preparedly. So you know which plate you will use, what size of the length of the screw you need for each patient. So before to perform the procedure, you know everything, the size of the length of the pectus plate, the length of the screw, so you know everything. Okay?
If there is a rotation of the sternal plate,
So in this case, it says rotation around 20% degree.
Okay.
20 degree.
my question, the plate has to be transverse, or I can make it as oblique?
No. The external place is placed in the depending of the rotation, of the angle of the rotation. But it's placed like this. Okay? The rotation is there is
This one.
yeah.
Has to be transverse or can be...
No, transverse. Yes. Okay? So for example, this case is 20 degree of the rotation in the right side. So we place already the external plate with the 5 screw. So we fix too strong. We use this dynamometer, yes, and you feel when you need to stop, okay? In order to avoid the rupture of the table. When all screw were done, so we place this another new device, the ball joint. So it's really easy, huh? Play like this. And then, so it's very important when you perform the pocket, you need to do in one side a very long pocket, because you need to place all the pectus plate in one side to go to the other side, you know, to play in the good position. So one side, the pocket need to be very longer in the other side. So when everything is done, so you place the plate, and with this also new device, you place on like this, okay? You go in contact to the plate, and now you start the reduction. Okay, you start the reduction. One tour, you win 2 millimeters. You go very slowly. But even when the external rotation, you win, the external go until normal position, you know? And it becomes symmetric, like this. Sometimes if you need more reduction, you can to prevent in the plate. Because finally the reduction is limited with the highest points of the each side, you know. But you can to banding a little bit, you win more. ¿Listo? Tenlo fuerte. Falta, ¿no? Now we are in contact Now we are in contact, external plate with the pectus plate. And now we fix only with 2 screws, and that's it. So also they are different length of the screw, and you fix. So you can try, but it's really easy and very safe when you perform this kind of the procedure. It's nothing to compare with the original technique that at the time we used the steel wire through the sternal bone, but today it's really, really, really easy. And now when the reduction is done, so you remove it, this part, using the drill. And this is the result. You place the drain, and you close the skin.
It's made of steel or titanium?
Sorry?
The metallic parts are made of steel or titanium?
So most of the time it's steel, but
Okay. You have to remove it after some time, or if it's left permanently.
very, very good question. So the idea is to remove it like the NASA bar 3 years after the procedure. But so the question is,
How long?
3 years. Yeah. But the difference is very two main difference. One of them that in case of arrests you can to perform the RCP. So in pediatric patient, the chest can be growing, different with the NAS bar. But also there are some patients that prefer to keep the plate forever.
For how long it's forever?
For me, forever, no, but you know that this new device is new, so we need very long follow-up.
How many years? The longest?
The longer is, in my experience, it's 8, yeah.
Some of the patients have, thin skin, so the edge of the plate, they can feel it, and that cause pain. So do you need to reshape the plate and these kind of patients?
No, the reshape is only the banding the bar is only if you consider that if you win a little bit more the reduction, because sometimes one of the difference compared to the Pectus bar is that the reduction is limited with the highest point of the at level the deepest point. You are limited in that because the Pectus plate is so poor. And the highest point of, yeah.
Sometimes the edge of the plate can be visible outside.
No, because you place the Pectus plate under the muscle.
But this system
Yeah,
is better than.
yeah.
Do you have some data when you remove the bar, how many patients present again Pectus? Or is it
So from the clinical trial, there were 18 patients who were treated in 2015-16, and hopefully this 2022 we will publish an article with the results of all these clinical trial patients with the removal of the implants.
and how many present another one?
So far, none. But let's see in this article what appears.
What were the complications after this procedure? Were there any?
I have nothing to disclose with this company, so I am just used for Pectus Up for in some cases. So they are two. I think that this new generation is different. That the first one, the generation is totally different, because the fixation is different. You know that from the beginning, the original technique placed the bar under the subcutaneous position and fixed the plate around the costal, the cartilage costal. So sometimes the steel wire broke the cartilage or broke and sometimes there are the mobilization of the plate. So we move it to fix the plate with the steel wire through the external bone, and it's better. But however, with this one, it's still better. That probably we will have less complication with this new method of fixation than the original technique. So this is the really new generation. So we have not the follow-up with this, but my feeling is that it will be better with the original technique.
Thank you, Dr. Lopez, for the demonstration. I have two questions. First of all, how many did you remove in your experience? And the second question, did you ever needed two of these systems?
The second question is?
If you ever needed more than one of these devices for asymmetric pectus? Yeah. Yes?
So well, from the beginning, I performed between 12 to 50 cases, and I removed around only 5 to 6 plates.
How was the removal? What's your experience in removing the...
So well, this new generation, even also the plate is different. So this kind of the plate is now actually very low profile. So it's probably is easier to remove it today than the last generation. So sometimes because the original technique, the original bar have several holes. You know, when you have this different hole, you know, they are the ossification and all, and sometimes it's very difficult to remove this kind of the bar. So today with this one, that is, you know, that's quick difference, is really easier to remove it.
So you implant one bar or two, or how many?
No, just one.
Could you repeat the question he made so the people who is online can listen to you?
Yeah.
One is enough for all cases.
Sorry?
One is enough for all.
Yes. So
So didn't ever needed a second one?
well, this is a good question. So
Yeah, so people can listen to
Okay.
the question.
for me, the indication of the Pectus Up is in Pectus Excavatum, when the deformity is placed in the lower part of the sternal. But for example, in Grand Canyon is very, I think that it's very difficult to obtain a good result with only one bar. Maybe in this case, you can use 2 bars, but probably
Two bars,
to play.
two separate incisions, or
Yes, it's 2 separate, yes, because even when you perform the Pectus, the NAS procedure for the Grand Canyon, you need several bars. You cannot to obtain good result just with 1 bar. It's the same concept. But with this, with Pectus Up, in this kind of the patient, require two two incisions, one in the lower part and the other in the upper part. But I don't have.
How you correct the oblique position of the sternum? How you correct?
Could you repeat the question?
Can you repeat how you correct the oblique position of the sternum? You know, the sternum which is like this.
In case of external rotation.
Yes.
So that is very important to place the sternal plate in the good position. That is the key point. In order to obtain a good result, you need to place the sternal plate in the good position. What do you mean? Good position is, for example, if the rotation is like this, you need to fix like this, not like this, like this. Okay?
And do you have, in your experience, somewhat displacement of the bar or loosen the screws?
The majority of my patients, we use not this new technique. We use the steel wire and fix through the sternal.
And the wire broken?
Sometimes yes, but probably this new method of fixation is better and avoid all this kind of complication.
I have
So the
several.
concept is really is better.
I have several questions. First, how would you recommend to position the bar in relation to the rib, if you have the perpendicular part of the bar? It's better to bar to be in the intercostal space directly on the rib or between. So, how would you position? What is the
So
best?
the position is you need.
You may choose.
Yes.
Every time you may choose.
So the position of the pectus plates is at level. You place at level to the deepest points.
I understand that 1 centimeter up or down, it causes
No,
the.
just exactly to the deepest points, and once again, the length of the plate is depending of the is evaluated under the CT scan. So you evaluate the length of the pectus plate, and you place the plate at level to the deepest points, and you choose the highest point. So you place
And the position of the bar in relationship to
No, the
the ribs,
position
it
is
doesn't
longitudinal.
matter. It doesn't
No.
matter.
No.
Intercostal space or
Yes.
over the rib. Okay. The second question, from your experience, do you see any contraindication for the use of this system?
any contraindication. So for me, to use several Pectus Up, for example, for Grand Canyon, for me, I prefer.
So long and deep deformities are the
yes.
relative contraindications.
Yes, once again, you need to have different strategy for different patients. So probably not all chest wall deformity can be benefit with the Pectus Up. So you need different approach, different strategy for each patient. So once again, the more important indication, you know, that when the deformity is in the inferior part, but even in symmetric and asymmetric cases, with this new method of fixation, I am more convinced that the Pectus Up work in this kind of the patient. But also the patient with history of cardiac surgery or recurrence, or yeah.
And the last question, what kind of screws are there in the system? Are they locking, are they self-drilling or self-tapping?
They are self-drilling. That's why we use the drill just to tap the first cortical, so they go in easily. And because the sternal plate then, as you might see here, is completely hidden because of the pectus plate, and there is no need for self-locking because they cannot migrate because of the physical obstacle. And I think we are quite late, so if you want to try it out, now it's time. Thank you, Dr. Manuel. Thank you, everyone.